Moral distress is really about the anguish that clinicians often feel when they're confronted with situations where their integrity is being compromised. And one of the elements of this is that clinicians often recognize there's a moral problem. They go through a process of discernment to think about what would be the right thing to do. And then for whatever reason, either because of internal constraints or the external environment, they're really not able to act on what they think is right. And the consequence of that is often a very profound sense of anguish and suffering, and a sense of violation of their sense of being a good nurse or a good doctor or whatever their role is.
Well, what we say is that when a nurse has moral, or any healthcare provider has moral distress, is that they're in an integrity compromising situation. Now, your integrity is when you act according to what your beliefs, and so when you're not acting according to your beliefs, and you do that over and over again, you're going to get some moral residue. And what I always say to people is that when you don't act on your feelings, okay, you're either going to implode or you're going to explode. If you implode, that is going to have consequences physically, emotionally, spiritually, depending upon what your weak link is. Hans Selye, the founding father of stress research, talks about the fact that we all have a weak link depending upon our family history, or depending upon how well we've taken care of ourselves. So wherever that weak link is, that could implode. It could be a migraine, it could be low back pain, it could be a heart attack. God knows where it's going to go. Or you can explode, and by that I mean that when you trap emotions in, it's like a champagne cork effect, okay? And eventually they're going to come out. Now they could come out in an anxiety reaction, which is the fear side of stress, or they could come out in an anger reaction. And so the healthcare provider could look like they're over the top in their reaction to the situation, and then it ends up getting discounted. Oh, it's just her, look at, why is she or he responding like that? And so it doesn't get focused on rectifying the situation, which actually was the cause of that individual's moral distress.
We began to hear in these narratives this idea that one situation raised distress, then that situation resolved, but the staff was left with this what's called moral residue, which is a really bad feeling that you did compromise your agency, and it's a very powerful and negative feeling that you're left with. And then here comes another case, just like that case. And so your distress rises again. In fact, it rises even higher. And after 4 or 5 of those, you have what we call the crescendo effect, which is that my residue and what is remaining from each of these cases is crescendoing, and therefore when a new case comes in, I just go, oh no, here we go again. And you will hear nurses and doctors say this, oh no, this is just like Mr. Jones. Oh no, I can't stand it, we can't do this again. And it's that residue, it's that memory of these difficult cases where the distress was not acknowledged and dealt with that creates this crescendo effect.
I think that the real answer to these issues has to do with preventing the situations from ever arising in the first place. That means when you have a critically ill patient, making sure that decision making is occurring, focusing upon what's known about what this patient would want and what is in the patient's best interest. It means having programs in place to deal with pathological grieving, which very few places do. And pathological grieving not infrequently leads to decisions being made that are not in a patient's best interest, that then lead very rapidly to moral distress among intensive care unit teams. It means making sure that when there's multiple choices to be made, that there is a fully informed shared decision. It very frequently is not the case in a whole variety of settings.
I would suggest that this is actually endemic to being a healthcare provider. You're going to have periods of being very distressed, of of confronting issues about yourself, about your work, about your environment that you might not know how to deal with. This is going to happen all the time. If you know this is going to happen, you're at least prepared. The other thing is, if you know this is going to happen, you can help create an environment in which you can support others, because when I'm not going through it, maybe you are. So I can work to help create an environment in which we can take care of one another. Again, setting up a community, a moral community, so that we're not simply people that occupy roles, but we treat our environment as actually a community, and we treat each other as community members, people that we share deep affiliation with. You can only do all that if you begin with a recognition, and that's the role of education, to begin with the recognition that this is part of the environment. So don't treat it as something strange that pops up and then you have to be reactive, but treat it as something that is endemic, part of the context and the experience of being a healthcare provider, so that we can work through it continually, forever.
It's a really interesting time in healthcare right now. On the one hand, things are in a lot of chaos, and there's an opportunity, I think, to use that chaos to invite people into, we have to work differently together. We have to think differently about how we provide care. We have to think differently about how we sustain our workforce, because they are a scarce resource. And so organizations may be a little bit more open to suggestions that are not just about the problem, but part of the solution. And so we've got to get clear about what are the many factors that contribute to these situations. We need to do that more systematically, where we can actually document through a process. Here's the case, here's the root causes, and here's the way forward, including individual and system reforms. And I think that doing those things simultaneously probably has the most potential for making change. I often have thought that people have to suffer long enough and enough before they're ready to make change. And it may be that we're close to that threshold in our own professions and in our healthcare system and in our society, I hope, because it is a very important issue. It is one that, we have to do something to address. And I think that maybe these factors will create the environment where that can happen.